Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, we're continuing with our ongoing series entitled, What's the Point? And we're in section 2 of this series, and section 2 is entitled, The New QME Conservatism. So in section 1, we talked about important principles of the physical examination, and there were 3 parts to section 1. In section 2, the new QME conservatism, we started off by talking about the new conservative approach to your AOE, COE determination, the determination for or against industrial injury. And more QMEs are adopting a conservative approach to opining for industrial causation. In other words, QME doctors are requiring stronger and stronger evidence of an industrial injury before putting their signature on a report that opines for an industrial injury. And this is actually consistent with law. Labor Code 3600 tells us that the burden of proof for establishing an industrial injury lies with the injured worker. And many doctors unknowingly assume the injured worker's burden and shoulder the burden of proof to try and prove an industrial injury, when in actuality it's the injured worker who has the responsibility to prove, and this is according to the letter of Labor Code 3600, to prove by quote-unquote a preponderance of the evidence, unquote, that an industrial injury occurred. And so doctors are requiring more and better documentation to evidence an industrial injury prior to opining for industrial causation. So that's a new conservative approach that we're seeing being applied to the AOE and COE determination. In today's discussion, I want to talk to you about the new conservative approach that's being applied towards the permanent impairment rating. Doctors more and more are opining for lower and lower and even 0% permanent impairment ratings at the permanent impairment evaluation, because they're simply finding that many examinees, and maybe even most examinees, with just a very few exceptions, most examinees, by the time they get to the permanent impairment evaluation, actually have all of their objective findings resolved. Their condition has returned to pre-injury status. They've returned to their pre-injury level of physical function. And at the permanent impairment evaluation, examinees, despite what they say subjectively, actually have no limitations to activities of daily living. Now, I know many examinees will describe subjective limitations in activities of daily living, but on close questioning, doctors are discovering that indeed most examinees are fully capable of doing whatever they want, whenever they want to do it, in whatever manner they want to do it. And they actually have no true, actual, objective limitations to activities of daily living. And so in that case, doctors are opining for 0% permanent impairment rating, or very low numbers, a very conservative approach to the permanent impairment rating. And this is actually supported in the AMA guides, and I'll go over a couple of references from the AMA guides here in just a minute. In our very next session, part 3 of section 2 of this new series entitled What's the Point?, we're going to conclude the new conservatism by talking about a new conservative approach to apportionment. So that'll conclude section 2 of this new series. Again, section 2 is entitled The New QME Conservatism, and part 1 was a new conservative approach to AOE COE. Today we're talking about a new conservative approach to the permanent impairment rating, and in our next session we'll talk about a new conservative approach to the apportionment determination. And then after that, we'll go on to section 3 of this new series, which we'll talk about at a later time. So for today, we're focused on the permanent impairment rating. And so I'm going to share with you a couple of references to support today's material. I have with me here the AMA guides, and I'll go through a couple of references from the AMA guides. And then I want to share with you an interesting case that illustrates today's principle, and it's the Cavallo versus the Department of Corrections case. And just to give you a little bit of advance notice about a little bit of heads up as to where we're going with this. In the Cavallo case, the doctor actually opined initially for 0% permanent impairment rating for the orthopedic portion of the injury. He then reversed his opinion by providing a different impairment rating under Alvarez-Guzman. It seemed that perhaps he was intending or trying to get a better result. And when all was said and done, the Workers' Compensation Appeals Board judge found that the new alternative rating under Alvarez-Guzman did not qualify as substantial medical evidence, and the judge relied upon the prior 0% permanent impairment rating as the final and conclusive permanent impairment rating. And I'll share with you the reasons why the judge arrived at that conclusion, because it's illustrative for us as we go through the process of trying to determine what is the most accurate representation of our examinee's permanent impairment at the time of the permanent and stationary evaluation. That's the whole nature of the AMA guides and the whole nature of the Alvarez and Guzman decisions. And that is, we as qualified medical evaluators are charged with the obligation. And by the way, it's written in law. It's written in law that in cases of permanent impairment, we need to consider an Alvarez-Guzman alternative type rating. It's required. It's not optional. It's required. And the whole purpose of this is so that we can arrive at what's referred to as the most accurate rating. Well, what is the most accurate rating? The most accurate rating is the rating that's the closest description and the closest representation of the examinee's true level of physical function on the day of the QME evaluation. It's all about arriving at an accurate and true description. And so doctors are finding that lower or no permanent impairment rating at all is actually the truest description and the most accurate description for most examinees. And we'll talk about the reasons why that is in just a moment. So I want to ask you to take a moment and get your AMA guides out, because I want you to lay your own eyes on this important reference that we're going to go over here together. So I'll come back with you in just a moment, and I'll give you a moment to go ahead and get your AMA guides. And I look forward to being back with you here in just a moment as we begin part 2 of our new series entitled The New QME Conservatism. And today we're focused on true and accurate permanent impairment ratings. And if you have your AMA guides, I'd like to have you turn to page 5 for me, please. Page 5 is in chapter 1, important chapter in the AMA guides, which talks about the philosophy and the use of the guides. And it's interesting, many of the subsequent case laws and important case decisions that have followed the 2005 adoption of the AMA guides rely heavily on descriptors and descriptions from chapter 1 of the AMA guides. So just as you should be intimately familiar with other chapters in the textbook related to your specialty, you also need to be very fluent in chapters 1 and 2 of the AMA guides, because they describe important overriding philosophy regarding the use of the guides. Well, one of those important philosophies is found on page 5, bottom of the first column. And here it says, it's talking about accurate permanent impairment ratings. Accurate permanent impairment ratings. So here it says, and this is a quote, it says, a 0% whole person impairment rating is assigned to an individual with an impairment. Okay, so they have an impairment. This is not talking about individuals who have no impairment, and we certainly have those as examinees. We have examinees who come to us portraying that they have an impairment, but on physical examination, they have a completely normal physical examination, and we're unable to identify an impairment. Remember, an impairment is a loss of use, or loss of function of any body part, region, or body system. So the guides are talking here about people who actually have an impairment. Okay, so let's start over. It says a 0% whole person impairment rating is assigned to an individual with an impairment if the impairment has no significant organ or body system functional consequences and does not limit the performance of the common activities of daily living indicated in Table 1.2. So persons with no impairment qualify for a 0% permanent impairment rating, and persons with an impairment, and this quote describes persons with an impairment, persons with an impairment also qualify for 0% whole person impairment rating if that impairment has no functional consequence or does not limit the performance of activities of daily living. So many examinees come to the permanent impairment evaluation portraying an impairment when there is none. Many examinees come to the evaluation with an impairment and exaggerate the functional consequence and exaggerate the limitations and activities of daily living when in actuality there are none. So a new conservative approach to the permanent impairment rating is, number one, to identify those examinees that, number one, do not have an impairment. They actually have a normal physical examination. And number two, for those examinees that have an impairment, to identify those who have limitations with activities of daily living and those examinees who do not have limitations with activities of daily living. And examinees will exaggerate both of these aspects. They'll exaggerate the impairment, and number two, they'll exaggerate the impact of that impairment on their activities of daily living. So let me ask you, does it come to you as a new revelation that some, many, even possibly most examinees exaggerate? Does that come to you as a new revelation? Well, I want to share with you a couple of references from the AMA guides that serve as the material upon which that conclusion that I just shared with you is based. In other words, these are not my words. These are based on references that come from the AMA guides out of Chapter 18. So the overriding philosophy is that examinees will exaggerate, number one, their impairment, and number two, the impact of that impairment on their activities of daily living. That's our philosophy. So let me share with you a couple of references to support that philosophy. And these are references that you can rely on as you go into your very next evaluation. You can remember and draw to the forefront of your memory these references as you go through your physical examination with the examinee, and as you go through your interview and your activities of daily living assessment with the examinee. You can draw upon these references and be fairly certain that most examinees will tend to use a little bit of hyperbole in describing their physical limitations, and number two, their activities of daily living limitations. Okay? So this is a reference from page 585 of the AMA guides, and this is under section 18.7 entitled malingering. Okay, malingering. Okay, So it says here that malingering is a conscious deception for the purpose of gain. It's important to remember that there's an intention for gain. It's a purposeful misrepresentation for the purpose of gain. Okay? Most authorities declare that malingering is quite uncommon. However, there appear to be few data regarding its frequency, the frequency of malingering, that is. However, the AMA guides then go to describe a couple of different sources of data that do provide some information regarding the frequency of malingering. And here they cite as many as 4 studies. So the first study is a study that was authored by Fishbane, and these are all in the bibliography, by the way. And if you're interested in this material, you should print out these studies and read them thoroughly. I've done that. I've printed them out and I've read each one of them in their entirety. So the first study was described by Fishbane. Fishbane reviewed literature suggesting that malingering is present in 1.25% to 10.4% of individuals with chronic pain. So that's anywhere from 1 in 100 to 1 in 10. 1 in 10. So perhaps as many as every 10th person that you evaluate could be telling you a version of the story that's not accurate. Okay, they could be a malingerer consciously trying to deceive you for the purpose of gain. Okay, so that's one study by Fishbane. Another study investigated patients who had what they call unexplained intractable diarrhea. It's unexplained, meaning the doctor says, well, what's the cause of that diarrhea? And the patient says, I don't know. It's unexplained. It's also intractable diarrhea. Intractable means it's not able to be managed. So the doctor says to the patient, well, what do you do? How do you manage the diarrhea? And the patient says, there's nothing I can do that helps. There's nothing that works. It's intractable diarrhea. So these are people with unexplained, intractable diarrhea. 14% of these people had positive stool examinations for laxatives, although all of the patients had denied the use of laxatives. So on an intake questionnaire, studying these populations of people with unexplained intractable diarrhea, they gave them an intake questionnaire to ask them about their lifestyle habits, etc., as relates to diarrhea. So there's a box that says, do you eat dairy? And do you eat gluten? And are you under a lot of stress? And all these factors that could contribute to diarrhea. Well, one of the boxes asks, do you take laxatives? All of the patients checked the box, no, I don't take laxatives. And 14% of those patients had positive stool samples for laxatives. In other words, they lied. They lied on their intake questionnaire for the purpose of gain. It's called malingering. Now, we could talk all day long as to what would motivate a person to self-induce diarrhea and then seek medical treatment for diarrhea. We could talk about that till the cows come home. But the point for us in this video and in this session on the new conservative approach is simply to recognize that people do this for whatever reason. People do this. They consciously will try to deceive you for the purpose of gain. One of the things you can always ask yourself is, what is the possible gain? What are they trying to gain? Okay? Now, in this particular study, what happened was they had all these people coming to the clinic with unexplained intractable diarrhea who underwent thousands and thousands and thousands of dollars of testing and treatment with upper GI series, lower GI series, barium swallows, all these studies, thousands and thousands of dollars of studies, for people who would never get well because they're taking laxatives without admitting it. It doesn't matter how much treatment you give these people. They're never going to get well because they're using laxatives surreptitiously. In fact, that was the name of the study, surreptitious use of laxatives. And so the authors of the study, they came up with a test, they called it a stool sample, to identify people with laxatives in their system so that the clinic could save the thousands and thousands of dollars and not put these people through unnecessary medical testing and unnecessary treatment that would never work. Now let me ask you, in the workers' compensation system, do we have injured workers who receive thousands and thousands and thousands of dollars of diagnostic testing and medical treatment who never get well and who will never get well because they have no intention of getting well, because they're involved with a conscious deception for the purpose of gain? The AMA guides tell us that we can expect this. Okay? In another study, there was 333 people who claimed compensation for noise-induced hearing loss. Noise-induced hearing loss. These were people that worked at the airport, they worked in large factories, loud places, and they were losing their hearing due to constant and repetitive exposure to loud noises. So they're claiming compensation, and that's the key phrase. They're claiming compensation for noise-induced hearing loss. Well, how do you detect hearing loss in people? You give them a series of hearing tests. Now, most hearing tests are subjective. And I want you to go back to grade school. And you remember when the school nurse gave you the hearing test? They put the headphones on you and she dialed in a variety of tones. And you were to simply indicate, when you hear it, you would give her the thumbs up signal, right? Well, that's what they did with these claimants. They gave them some hearing tests and they asked them, do you hear the tone? And the claimant would sit there and they would put another tone and the claimant would sit there, another tone, no thumbs up. They would just sit there. Do you hear any tones? Nope, don't hear any tones. Meanwhile, all the while, these claimants were hooked up to an objective test, okay, not subjective tests. They were hooked up to an objective test known as cortical evoked response audiometry, which detects the nerve impulse in the auditory cortex to confirm that the examinee is actually processing and is actually hearing the signal. So despite an examinee's non-response, the objective testing is confirming that indeed their hearing loop and hearing mechanism is intact. 333 people, 17.7% exaggerated on the hearing tests. 17.7%. So we could call that 20%. That's like 1 in 5. So Fishbane described 1 in 10. The diarrhea study showed 14% liars. Here in this study, we're up to 1 in 5. 1 in 5 examinees could exaggerate on subjective testing in the context of seeking compensation. In this case, it was noise-induced hearing loss, but they were seeking compensation. Okay, finally, a study by Weintraub says that 20 to 46% of people consider purposeful misrepresentation of compensation claims to be acceptable behavior. Let me read that again. 20 to 46% of people. So 46%, that's almost 50%. That's almost 1 in 2. That's almost every other person. Almost every other person considers purposeful misrepresentation What is purposeful misrepresentation? Is that conscious deception for the purpose of gain? Is that exaggerating? Is that the use of hyperbole? Is that overstating? Is that understating? Is that telling a story that's different from the truth? The AMA guys refer to it as purposeful misrepresentation. They consider purposeful misrepresentation of compensation claims to be acceptable behavior. And so the guides tell us, if you believe the AMA guides, if you consider the AMA guides to be the Bible under which we operate in this system, the guides tell us that as many as 1 in 5 to as many as 1 in 2 people are malingerers. As many as every other person considers purposeful misrepresentation of compensation claims to be okay. It's okay. It's okay. And so the point is, there's something that takes place in the mind of a person when they're seeking compensation. And the new conservative approach to the permanent impairment rating is simply to understand this, to recognize this, to realize this in advance, prior to meeting with your examinee. And then simply going through your procedure, and still, despite the examinee's exaggerations, purposeful misrepresentations, denials, such as the denial of the use of laxatives, such as their conscious deceptions, despite what they say, we're still obligated to come up with an accurate permanent impairment rating. And the new conservative approach is simply to recognize that this phenomena exists, to recognize that examinees may have motives, to recognize and become comfortable with a little bit of hyperbole, and to come to expect it and simply be comfortable in dealing with it and be comfortable in handling it. The new conservative approach is to take the findings and reduce the findings by 14%, by 17%, by 20%, perhaps even as much as by 50%. Okay? We simply need to become comfortable with this, and we still need to come up with a permanent impairment rating that's true and accurate. And more doctors are simply concluding that very low permanent impairment ratings are accurate. Sometimes even a 0% permanent impairment rating is the most accurate description of the examinee's condition. And doctors will ask me, well, oh my God, could I actually provide a permanent impairment rating of 0? And doctors say that as if somehow they're going to be shot out of the universe in a space and time capsule, never to return to planet Earth, if they ever become so bold as to provide a permanent impairment rating of 0%. But our job is to provide permanent impairment ratings that are true and that are accurate. So if we know that examinees have a tendency to exaggerate and use hyperbole on the physical exam by understating their physical capacities on physical exam, and if we know that they overstate, so they understate their capacity on physical exam, this is one way they exaggerate. Another way they exaggerate is by overstating their limitations in activities of daily living. So if we simply recognize that and realize that, we'll realize that many examinees have no true positive objective findings on physical exam. In other words, they have a completely normal physical exam, which qualifies for 0% permanent impairment rating. And number 2, they have no true limitations in activities of daily living, which also qualifies for a 0% permanent impairment rating. Now, examinees will overstate their limitations on activities of daily living. So let me give you an example of a sample dialogue between a doctor and an examinee. Okay, and this is how things typically go if you do a thorough activities of daily living assessment in the face-to-face evaluation with your examinee. So doctor says, Mrs. Jones, Do you have any limitations with self-care and personal hygiene activities? For example, do you have any limitations with bathing, dressing yourself, and combing your hair? Mrs. Jones: oh yes, bathing, dressing myself, and combing my hair is very difficult, and it's a tremendous struggle for me. Doctor: Mrs. Jones, I understand. Let me ask you, did you bathe and dress yourself and comb your own hair in preparation for today's appointment? Or did you require assistance from another person? Mrs. Jones: oh no, I did all those myself. It just was very difficult. And what do we have here? The truly objective finding, despite what Mrs. Jones says about the difficulties, is that she was able to bathe herself, she was able to dress herself, she was able to comb her hair and arrive on time for the scheduled appointment. No true limitations in activities of daily living. Let me give you another example. Mrs. Jones, let me ask you, do you have any limitations with travel activities? For example, do you have any limitations with being able to drive your car? Mrs. Jones: oh yes, sitting and operating the pedals with my feet causes me tremendous back pain, and it's extremely difficult. In fact, I don't even like to drive except for very short distances. Doctor: I understand. Let me ask you, Mrs. Jones, did you drive yourself here to today's appointment, or did someone drive you? Mrs. Jones: oh, I drove myself, but it was very, very difficult. No true limitations, despite subjective overstatements. She's actually able to drive. She's able to bathe herself. She's able to dress herself. She's able to comb her hair, as evidenced by the fact that she's here, she's groomed, she drove herself. And if you question your examinees carefully, you'll discover that very few have true limitations in activities of daily living, and they qualify for either 0% or very, very low permanent impairment rating. Okay, doctors? So I'll give you just a moment to think about that, and I'll come back with you here in just a moment. As we conclude today's program, I want to share with you a very interesting case that illustrates this principle beautifully. So I look forward to being back with you here in just a couple moments. Okay, so I hope you took a moment to think about that. These are some topics and discussions that are quite frank and that you won't find anywhere else. But I think it's important that we discuss topics and issues that face every single one of us with every single one of our evaluations. You know, I talk to so many doctors, and doctors will tell me things like, there was just something about the examinee that wasn't right. There was something that didn't feel right. There was something that was a little strange. There was something about the physical exam that was a little bit incongruous. In other words, doctors tell me that when they're with examinees in the workers' compensation system, and this is not every examinee, I'm not categorizing to every single examinee, but I'm saying that many examinees, maybe even most examinees, have external incentives going around in their mind. And doctors will tell me what they feel in their gut, and that is that something doesn't feel quite right. And I'm telling you, get comfortable with it. Get comfortable with it. The AMA guides tell us that as many as every other examinee, and it may even be more. It may even be more. By the time we get to the qualified medical evaluation, sometimes 1 year, 2 years, 3 years has passed since the injury, and at that point it may even be more. Many examinees have external incentives going on in their mind. So get comfortable with it, okay? And it's just important that we recognize this and that we deal with it collectively as a group and that we handle it appropriately and come up with a permanent impairment rating that's still accurate. It's not inflated. It's not understated. It's neither too high nor too low. It's accurate, okay? Well, I want to talk to you about a very interesting case that illustrates this principle. This is the Calvillo versus the Department of Corrections case. This is a 2015 decision, so a very recent case. Okay, so Miss Calvillo was a sergeant at the Department of Corrections, and one day she suffered an orthopedic injury as an inmate took her hand and jammed her hand up against the cell bars. So she had a contusion to the back of her hand and wrist. There were no fractures. There were no dislocations. There was no diagnosable ligament sprain or resulting carpal instability. It was simply a contusion. Now, the date of injury on this, do I have that? This was a 2011 date of injury. So prior to 2013, we used to have the compensable consequence injuries for psych, sex, and sleep disturbance. So in addition to the orthopedic injury, Ms. Calvillo claimed injury to the psyche as well. Well, time passed, she received medical treatment, and she was determined to have 19% permanent impairment due to the psych injury, but for the orthopedic injury, the QME or the AME, it was an AME. The AME said that Ms. Calvillo qualified for 0% whole person impairment because he was not convinced that Ms. Calvillo was putting forth full effort on her physical examination. He did grip strength testing. He found that she produced a grip strength of 0. Of 0. Okay, that's not even compatible with being able to hold a car key, okay? She produced a grip strength rating of 0 following a wrist and hand contusion. No fractures, no rupture of the triangular fibrocartilage, no interosseous ligamentous tear on MRI. It was simply a contusion, okay? And so after time and treatment, you would expect some recovery, correct? Well, on evaluation, the qualified medical evaluator, in his clinical judgment and in his experience, he opined for 0% impairment because he felt that she was understating her physical capacity by physical exam. He wasn't convinced that she was sincerely participating in the exam, okay? Well, after the doctor issued his opinion for 0% whole person impairment, he received a request for a supplemental report wherein the applicant attorney requested a reconsideration of the permanent impairment rating under Alvarez and Guzman. So the applicant attorney suggested that perhaps there was some other alternative impairment rating. In spite of the confounding and confusing physical exam findings, perhaps there was some alternative rating that would be an accurate representation of Ms. Calvillo's loss of use and loss of function of her wrist and hand. Well, the doctor was not comfortable with that, but he put some thought to it, and he provided a permanent impairment rating using the direct estimate method. So we know that the upper extremity qualifies for 60% whole person. And the doctor came up with an estimation that Ms. Calvillo had lost approximately 20% of the function of her right upper extremity for various activities such as pushing, pulling, gripping, grasping, fingering, push, pull, lift, and grasp with the right upper extremity. He estimated that she had lost 20% function. Well, 20% of 60% for the entirety of the upper extremity is 12%. So the doctor issued a new permanent impairment opinion, a new rating opinion, for 12% permanent impairment due to loss of function of the right upper extremity. He used the direct estimate method. According to the charts and tables, he came up first with 0%, but on Alvarez and Guzman reconsideration, he came up with a rating of 12%. Well, the defendant objected to this. The case went all the way to the Workers' Compensation Appeals Board, and the judge ultimately provided an opinion for 0%. Okay, she still got 19% for the psychiatric injury. Okay, but he opined for 0% for the orthopedic injury, despite the doctor's reconsideration for a 12% rating, because the judge himself did not find the new opinion of 12% to constitute substantial medical evidence in the context of an examinee who did not fully participate in the evaluation. So the judge reversed the 12% rating and relied upon the 0% rating. In fact, the judge imposed the 0% rating based upon the doctor's own statements. The doctor's own statements, particularly when the doctor explicitly questioned applicants' credibility and where there were no and or minimal objective factors of disability or impairment. And the doctor's opinion regarding 20% loss of capacity percentage was inconsistent with his expressed reservations as to applicants' credibility and the AMA guides, which emphasizes objective assessment of impairment. Is that incredible? Is that incredible? And so the judge himself took a new conservative approach to describing the permanent impairment rating. That's the Cavillo case. She still got the 19% for the psych injury. I'm surprised that that wasn't further disputed as well. But the orthopedic injury, it makes sense that following a simple contusion with no fractures, no tear of the connective tissues, time and treatment, wouldn't we expect an examinee to have some recovery after time and treatment? And so the doctor found 0%, the judge opined for 0%, and it makes sense. These conservative impairment ratings make sense when you look at the overall context of the case. So doctors, if you remember that as many as 1 in 5, maybe even as many as 1 in 2 examinees will exaggerate both on physical exam by understating their ability. That's what Miss Cavillo did. She took the grip strength tester and she understated. In fact, she understated it all the way to 0. The grip meter didn't even come off the pin. She understated her capacity and the doctor didn't buy it. She overstated her limitations with activities of daily living and the doctor didn't buy it. So if we simply realize that this is a common phenomenon, we don't pass judgment on it, it's just something that simply happens in compensation cases, we can just consider it in advance, recognize it when it exists, and handle it. And come up with a permanent impairment rating that's a true and accurate representation of the examinee's condition. Even if that permanent impairment rating is 0% whole person impairment. Okay, doctors, I want you to simply become more and more comfortable with this idea. So doctors, I hope this helps you. You know, this is a tremendously difficult job that we do as qualified medical evaluators. And if you're anything like me, I'm simply concerned about what's the truth, what's right, what's accurate, what does the examinee qualify for? I, probably like you, want the examinee to receive every single benefit that they're entitled to under the law. But like the defense attorneys who I have a chance to speak to on occasion, we don't want to provide unnecessary benefits that examinees don't qualify for. We want them to get what they qualify for. We want them to get exactly what they qualify for, but not more. than they qualify for. I'm concerned about what's accurate, and I'm sure you are as well. So I hope this idea helps you in arriving at permanent impairment ratings that are a true and accurate representation of the examinee's actual condition. In our next session, we're going to talk about a new conservative approach to apportionment of the permanent impairment, and we're going to find that examinees have many other factors that contribute to the permanent impairment. So we're going to learn to become more and more comfortable with apportioning a larger and larger percentage of the permanent impairment to what are referred to as other factors. So look forward to being with you on next week's video as we conclude Section 2 of our new series, which is entitled What's the Point? Section 2 is all about the new QME conservatism. Part 1 was a conservative approach to AOE-COE. Today we handled a conservative approach to permanent impairment. And next week we'll handle a new conservative approach to the apportionment determination. So doctors, I hope this helps you, and I look forward to being with you again very soon. For now, I'm wishing you best of success in your career as a qualified medical evaluator.